Hello there, this is Kent Campbell with another therapist training video. I'm thrilled today to be here with my colleague Brandy Vanderheiden, who is, like me, a marriage and family therapist in Santa Clara County. And this is our chance today to think and talk together about somatic approaches to psychotherapy. I will talk about why we're here and then ask you to introduce yourself, Brandy. I'll say that part of why we're here that you and I have already spoken about is that when I'm teaching graduate students in counseling psychology about the ethics of therapist conduct and how our therapeutic orientations impact the way that therapists interact with their clients and patients, that the vast majority of the information shared in my graduate level course is about ways to avoid touch and the dangers that are obvious and have been devastating that therapists who abuse their position of power, a lot of men in the therapist chair in particular, have hurt their clients from things that they've done by touching in ways that weren't welcome. And so that's where the bulk of the instruction comes from in my class. But I know that we're missing a whole lot here. And thus, here to talk with Brandy about ways that the body can be more welcomed, following an ethical code in ways that can be really helpful. And so, Brandy, I'll invite you to say anything you want to introduce yourself here and now.
Sure. Yeah. So before I went to get my master's degree, I was teaching yoga. I had come from an advertising background, and we had, one of those times where there were a lot of layoffs, and I'm like, what should I do? I'm going to go teach yoga for a while, but then started to think about what to do next. And it was JFK's holistic program that drew me because of the mind-body connection. Like in yoga, mind, body, and spirit are all related and they're fluid. Yes. And so I really wanted a psychology program that was going to work in that way and address our healing from that perspective. Yeah. And so from there, and that was, in 2004, I started the program there. And, as I was going through my traineeship, I got more and more interested in the somatic and ended up taking Peter Levine's training, Somatic Experiencing, starting in 2008. And the very cool thing about that is that when, we're doing our therapy, like I did my therapy that I had to do to graduate, and it was talk therapy, existential humanistic, and it was wonderful. Like I, got some really good growth from that. But what I found is that my very skilled managers, as they say in the arts work, is like I was very skilled at being able to, kind of nuance my way around some of the actual issues that were keeping me from living a more full life. Yes, and the somatic bits can really get underneath that into pre-verbal, nonverbal. And just things that we have put into our unconscious or non-conscious.
And so what you are describing that we've talked about just a few moments ago off camera is this way that using the body, and I'll ask you to define in a minute about what somatic therapy is, but you're describing a way that as therapists and as client-patient, we're able to use our body to get past the verbal and past our defenses, to access what some of our colleagues talk about as being the unconscious, to talk about parts work, to talk about things that are nonverbal. Because one of the things that I run into as a clinician who uses, Freud called it the talking cure, when I use my words to be in dialogue with people, we can get so far, and there are parts where my analysis and insight and the person's insight into their own experiences and dreams and otherwise can give them input, but there's a definite limitation, it feels like at times, to that pre-verbal part. And so thrilling to think about this piece. The parts I wanted to define were John F. Kennedy University, being the place that you finish your master's work from. And Peter Levine is the pioneer in this field, the most well-known. The other person comes to my mind, Bessel van der Kolk, and his The Body Keeps Score, to me, is the other part that I think about when it comes to trauma and embodied work, but all that impacting you, yes?
Yes, absolutely. Yeah. And a lot of people come to me because they've read Bessel van der Kolk's work or Peter Levine's work. The Body Keeps the Score has been on the New York Times bestseller list for 6 years straight.
You're kidding. I had no idea.
So,
Makes me think about all of us walking around with our traumas and trying to figure out how to make sense of this and work through.
yeah. And, he actually in the book describes lots of different therapies. He talks about EMDR, which actually is included as somatic in a
Okay.
lot of cases. Like that'll be included, especially now that there's brain spotting and somatic EMDR, where it explicitly comes back to the body.
No kidding. EMDR, eye movement desensitization work, where whether it's touch or visuals, but that there's something about that and the way that releases trauma. The legend I heard about that is that the woman who developed that was walking on the Los Gatos Creek Trail and having her eyes going side to side. That was where that came from here in San Jose. And you're saying that there are lots of different ways to think about somatic therapy. Can I ask you to speak again about,
Yeah.
and I kind of interrupted you to define EMDR, but about what this field of work is?
Yeah, a really great place to understand this is the U.S. Association of Body Psychotherapy, USABP.org. And they have like all sorts of, continuing ed training. They have a conference every 2 years. And so they get people that have been in the field since, the real place where it started was in the 60s. Think about Esalen and people experimenting. And some of that is, where things didn't go so well with what you were talking about before with touch becoming problematic. But a lot of great ideas came out of that, people working together and figuring out how to include the body. And so there are all these different branches of somatics. And so you get people like, who are more on the how does the brain work side.
Okay.
So it's like, okay, well, during trauma, like, certain parts of the brain will fire and create fight or flight responses. And they kind of keep it a little centered in the brain. And then there are people who more keep things centered in the body. And, Peter Levine has always been about the autonomic nervous system. And so it's how your body will automatically respond for you to try to protect you from whatever stress is happening. A lot of the people that come into our offices have the chronic stress where it's in a low level of fight or flight all the time.
I see.
And there is kind of reinforcement for that because that also helps people produce. So if they're able to harness their fight or flight into productivity,
yes,
then they are very reluctant to let go of that.
Because that makes me a real productive employee. If my stress and my motor is turned up fast, then I'm okay. But
Right.
that you're saying this is that there's a little bit of that fight or flight that impacts that. This isn't just coffee and excitement. This is
Right.
taking toll on the body.
It is the nervous system rallying fight or flight to run at that level. And some of that could be trauma influenced, or it could be from, their earliest patterns when they were born, and how they were received in the world was the nervous system that was soothing them, or hopefully soothing them, calm, or was that nervous system anxious? Was it not available? That will influence the patterns that people will choose to be able to survive their experiences.
Yes. I had a colleague say to me, I didn't necessarily choose to be born into this situation, but I was. And so whether I was born with a parent who was anxious, a caregiver who was avoidant, that baby is going to adapt to that scenario. And what you're saying is that those patterns, attachment research is what that makes me think of, that those patterns stay with throughout. And that this somatic approach is about using the body in therapy allow us to do what, Brandy? Or what's our hope in that moment?
Yeah. Well, in a way, there's the possibility for some repatterning. So just like in other forms of psychotherapy, you can make the implicit explicit and say, this might be what's happening here and why your body is responding this way, and maybe pushing people away, or, doing whatever things that people do in relationships when they are feeling threatened.
Yes.
Right. And so one of the common things that I see is that the dissociation from the body is pretty universal, because that's the culture that we're in. And this culture is probably even more that way than other cultures. And the don't touch anybody thing is especially intense here in the United States.
Isn't it ironic, despite all the ways that bodies are used in advertising, that in reality, much of our cultural expectations about kids and ourselves is not to be tuned into the body, to not be touching. And
Right.
dissociation, this idea that you would define better than I, but I would start by saying that we tend to ignore, to tune out, to separate, to not be present to things that are difficult. And that can be a way to survive traumatic instances, but it can have consequences about being disconnected, is how I would start that conversation. How else would you carry that further?
Yeah, and I think that it comes down to even people who are workaholics, that they're dissociating from their body and plugging into a computer, and they're completely unaware of their body's needs or any of that. They're numb in terms of being able to actually feel any experiences of anger or fear or joy, unless it gets to the level that breaks through as something like a panic attack or some kind of, GI upset or something
Yeah.
like that, headaches.
Makes you
Right.
think of not being connected to pleasure also as being another way about disconnected in the body. And when you say make the implicit explicit, as a verbal therapist, that makes a ton of sense to me, that insight and recognizing and announcing and speaking about things allows us to do something about it. And the thing that's dawning upon me is you're saying that the body can be used as a tool, a way to learn more if we're attentive to the body.
Mm-hmm. Yeah. And, I'm coming from a trauma background here. So, like whatever somatic branches do might be different around this.
Yeah.
But, one of the things is that we talk about window of tolerance. And, a lot of times in things like DBT, it's like they're talking about largely like behavior management, like do you get overwhelmed and then lash out or things like that.
Yes.
But we want to work on an even further back level and help people see that their nervous system has a window of tolerance, and that very early on, you're going to start managing. If you start to feel something shaky inside or uncomfortable or
Yep.
tight, you'll just maybe blank out, or you'll move away, or you'll get on your phone before it's gotten anywhere near rage or lashing out. So if we work on these really small titrated levels and get people used to feeling their body,
Yes.
they start to grow the capacity to feel it more without having to do anything about it.
Even unconsciously, about disengaging.
Mhm.
And so it's a spectrum, right? Disengaging, tuning out, let me check my phone, dissociation, I'm not here.
Mhm.
ACT talks about moving towards people are moving away, and you're saying like there's a way to engage and connect if we're able to be attentive. And
Right.
window of tolerance, before I feel overwhelmed, how much can I sit in this present moment experiencing?
Yeah. And the thing is that I always treat these management strategies as a friend. But, it's like, thank goodness you came up with that, because look, it got you here today.
Right.
But what you want to be able to sort for is like the ones that you're going to keep, like humor or,
Yes.
things that are, I'm on my phone, maybe I'm on my phone too much, but the world isn't going to end. Right.
Yes.
Versus I'm turning to alcohol or drugs or, other things that get us into trouble.
Exactly. Or the way you said that anxiety can be so overwhelming, I feel like I'm having a panic attack and I can't, it's too overwhelming for me to sit with these bodily sensations.
Mm-hmm.
Can I ask us, I interrupted you when you started with EMDR, and you were saying that there are a whole many different ways of thinking about using the body in psychotherapy. Do you mind spending a moment talking about different parts of that perspective?
Mm-hmm. Yeah, I mean, it's really like different pioneers have come along and had different ideas. And so that's one piece of it. Stephen Porges has given a big gift to Do you know the polyvagal
Bagels,
theory?
right.
Yeah. And that introduced us to the idea that there is a social engagement network in our nervous system, and then this other network that takes care of fight, flight, or freeze for us, right?
Hmm.
And so then there are people that kind of run with that, and there are other ways in that people do. So I'm most familiar with Peter Levine, but there's sensory motor psychotherapy and Hakomi, both of which are not necessarily trauma specific.
Hmm.
In sensory motor psychotherapy, one of the trainers, Janina Fisher, is well known now through PESI, and she does a lot about dissociation, fragmentation, shame, and she is from a sensory motor psychotherapy background. So she's doing amazing work there.
Super.
But when you talk about what forms of touch we use in psychotherapy,
Yes.
I'll just go through a little list because, a few years ago, I created a 6-hour training in the ethics of touch that I'm not currently running, but forms of touch in therapy. So you have a greeting and farewell. You shake hands, right?
Yes.
Okay. You have conversation markers. Well, let me just tell you, Kent, right?
And the hand on the shoulder, the knee.
Let me just, yes, I totally hear what you're saying, right?
Yes.
You have something to get their attention. Oh, there's something's about to fall on their foot, oh, here,
Yes.
An accidental touch, you're passing a pen.
Yes.
Right? For comfort, let's say they are sobbing and you place a hand on a shoulder, right? Or on their upper back. Okay. And then the last two are ones that you need training for if you're going to do them. The first ones are, I'm a human being in the room.
Yes.
And what I would say about that is to know your own history of touch and your own cultural experience of it. It would not be natural for me to reach out and just pat somebody willy-nilly. Like, even if I weren't who I am doing this work, that's just not part of like my touch repertoire.
Yeah.
But for some people, that's going to be very natural for them.
And it makes me aware it's the therapist culture and then the client's culture, what the client's open to also. Yep.
Exactly. And that you might not totally know. You're
Right.
not going to be like, okay, is it okay if I touch you on your shoulder? Or whatever. So that's just like, usually I think people can tolerate just a little bit of like, if they just see it's like a little thing, but understanding where you come from and being able to separate, like, what is my need here and what is the client's need?
Is this a therapeutic intervention, or is this me doing this because this is something I, for whatever, want to do?
Right. And so, like, for example, I have my own little hug policy.
Yes.
Which is, if a client asks, I will hug.
Yes.
But I'm definitely not going to stand up with my arms open.
As if asking for them if they would hug you. Yes. Right.
And so that tends to work. There are some clients that would like a hug, and I'm happy to hug them. Yeah. And it might seem a little bit sterile for some people who come from more of a touch background, right? But that's, kind of like my personal and professional comfort zone.
Yep.
Mm-hmm. So I never want a client to feel obligated to hug, like they can.
Exactly. And my internet just froze.
Is it back
and
now?
You said that there's even a further touch. It is back. Yeah. Thank you.
Mm-hmm, mm-hmm. Yes. So then we have somatic interventions, which might be something like pushing hands.
Okay. Literally like this.
Yeah. My hands on your hands, and there's some pushing. So the way that we trained in somatic experiencing is the client comes with their hands here. We have a stance that can help support a stronger push, and then we allow them to give a strong feeling of push. And there are some reasons for that, like if a person has a lot of collapse and they don't have access to a lot of fight energy.
Right.
So let's just move the limbs. We're not like, let's think about that horrible thing happen and try to recreate it. But it's like, let's get your fight or flight system on board and just see if it's scary or not, or how it feels, if it feels invigorating, right? And then we can kind of see what they say.
That makes sense to me. And this isn't like a rage room and like really overwhelming that part. It's, I can imagine for a client who's been when not in a position of power, to be able to push back and to have that experience. Even as I do that, I notice in my nerves along my arms that it strikes something within me. And so that would be one example. What else might that look like?
You could do like where like you lean into a person.
Okay,
So
on the side.
yeah, so like, I'm here, you're here, and then we just kind of lean, and there's this feeling of support.
Yes.
What I do sometimes is actually hand between the shoulder blades.
Okay.
And sometimes this is like just a way to help the person kind of be in the present moment with a supportive, attuned other.
Yes. Presence, connection, that the hand communicates to the body on the spinal cord that way.
Right. And, there was all this research that was done by Tiffany Field out of the University of Miami. And they talked about like the quality of touch and like all the different forms of touch, even like massage, and how it supported people, reducing anxiety and things like that.
Yes.
But that they figured out that in most cases, unless there have been certain kinds of trauma, which you can imagine, like that people can tell fairly quickly the intent behind touch.
Okay. And if a clinician is trained and skilled in knowing what kinds of interventions and how to do that, that might give the client an opportunity to experience something important for them.
Right. And so there's this whole layer of like, we have to work on consent first before we're going anywhere near doing a touch intervention of that sort, especially. We're going to spend some time, like, what are your thoughts about that? And they know I'm somatic when they come in, so usually they're kind of primed. But, the ability for the client to work through issues of consent and boundaries where boundaries might have been crossed.
Yes, of course.
Yeah.
The client has to, excuse me for interrupting.
Yeah.
The client who has had a boundary violation. So a boundary crossing is when a therapist chooses to do something unusual, like I'm going to disclose to my client something about myself. That'd be a boundary crossing. Boundary violation, someone has been hurt, injured, made unwell by what someone has done to them. When there's been a boundary crossing, and for a client to say, I'm okay with A, B, and C, but not D. And when the therapist respects that and gives the client the opportunity to practice that, that would be helpful.
Mm-hmm. Yeah, and so we break it down to as simple as possible. So, it might be that, the client puts their arm on the chair.
Literally.
And, yeah, like the edge of the chair. And I say, okay, so we'll go ahead and practice. And then when I put my hand on, we're going to see how it feels. And if it doesn't feel right, then you're going to say, I've had enough, or let's take a pause.
Yes.
And then they get to try that out, right? And they can notice like, oh, that felt a little bit scary at first, but then it was okay.
Yes.
And I'm basing this on the fact that we already have some relationship happening. It's not like 5 minutes after they've walked in the door.
Right.
And the thing that makes this interesting, but also tricky, is that there are people that will just agree because they want to not upset me. And so being able to sort that. Now, when I took my hand off, what did you notice? Like, oh, I kind of felt like I breathed a little bit deeper. That might be my sign that they were, kind of pushing through what they didn't want. And all that is good information.
And in my language, it's transference, countertransference. When I get the sense that my client is getting the heebie-jeebies from me, then that tells me something. And if they're afraid to tell me that they don't like this touch,
Mhm.
then that's information also. And we can talk about the way that they're not feeling comfortable asserting their boundaries, right? Communicating honestly. Yeah.
Right. And making consent like a very fluid and all the way through kind of process. So like the one of the things is like if I'm going to suggest touching, my hands are on my lap. I'm not like, can I touch you? They're like, whoa.
Yes.
And so I describe what I'm going to do very conversationally and then talk about options,
Yes.
and why we're trying to do it, what we think it's going to do.
Yes. What's the intention?
Mm-hmm.
Reading through it's like 12 pages of of ethical approaches to somatic treatment that you sent me from the organization you mentioned earlier, that we'll put a link to. So much about consent. And as you said, along the way, checking in and say, is that okay? Are you ready for this next step or not? That's essential.
Mm-hmm. Yeah. And the truth is that in most cases, the person feels a lot of relief. They're like, oh,
Mm-hmm.
that feels really nice. I
Mm-hmm.
can really feel, your presence there. It feels safe and gentle.
Yeah.
So I think we put a lot of focus on the, oh no, like I'm going to re-traumatize them and the fear side.
Yes.
But the reality is that's why I keep doing this is because it's helpful.
The healing and seeing how this changes people. Do you mind saying anything about that part about why someone would come in or what they would leave with or what treatment looks like? I'm not sure how else to talk about that, but like
Yeah. I mean, they can come in with anything. Usually they lead with, I've heard about somatic therapy and I've tried talk therapy and I want to try this level of it. So they're kind of coming in primed.
Yep.
But usually there are things that are going on in the here and now, stressors and anxiety and whatnot, garden variety of everything. And then there are sometimes particular traumas that they want to get to. But I think that just getting them familiar with how their nervous system responds to stress
Yep.
and starting with access to pleasure, like, non-sexual, just pleasant sensation
Yeah.
is where we try to start, because if you're accessing something that feels pleasant, then you're giving the signal to the autonomic nervous system like, oh, apparently there isn't a tiger that's chasing us or something.
That's right. Like on the cover of the Beans book.
Mm-hmm. And so that was where I was going to try a little experiment with you.
Oh, sure.
I'm going to make it nice and easy.
Okay.
It is if you take a moment and think about something that you enjoy, like something really pleasant that you did recently.
Okay.
Not 10 out of 10.
Okay.
Uh-huh. And just take a moment, drop in. And if there's an image or if there's just the memory of it, and you don't have to say it aloud. But as you do that, then see if you can tune in and notice what your body is doing
Right now, what my body's doing in this moment.
in this moment.
Would you like me to talk about it?
Yes.
So what I'll say is I went for a walk this morning in the sunshine, and I was remembering the sun and the warmth as I was walking with a colleague, and that part's there. And here right now, I noticed the part that I'm most aware of is the nervous energy in my gut that wants to do a good job with my thinking brain to make sure this interview goes well, but that otherwise it's almost like the memory of the heat on my that's weird, on my shoulders. I was wearing a shirt, and my skin was not in the sun, but I have this feeling of like warmth and like I don't know if that's joy, pleasure, contentment, but that's what it makes me think of.
Yeah. And it could just be warmth. It doesn't have to be a thing, right? So
Okay.
we want to give people that sometimes we tune in like that feeling in my stomach is anxiety,
Uh-huh.
and it's also something that feels kind of churning or something, right?
Okay. The
So
churning.
we're yeah, or something like that, you know. And we give people the opportunity to break things into smaller pieces. That's one of Peter Levine's big things. It's like you have maybe the story and the meaning, and then maybe there's a memory and an image. And with that comes an emotion. And with that comes the body sensation. Now, let's say you have a memory that is intense and like all of those things are tangled up together and they're
Yes.
too much to bear all at once.
Okay.
You say, all right, let's just see if we can take the story and set it aside for just a minute. And we'll come back to it because we want to make sure not to dismiss their story.
Right.
And it's like, oh, it's anxiety in my stomach. Okay. Okay. So now if we can just focus on what the feeling of anxiety is, and I
Yeah.
feed them words like I did with you, churning or tightness or whatever, so that it continues to lose its intensity. And when it's no longer all of the things together, but it's just one thing,
Yes.
they can be with that more easily in most cases.
More
And
tolerable. Did you say it fades away if we can sit with it? Because that I didn't understand.
it may. It often does. So
Hmm.
sometimes it'll have a little bit of a curve like that.
Okay.
Sometimes it'll just dissipate, or they'll be like, oh, well, now I don't feel anything, right? Because the dissociation has come in.
Yes.
Now, if let's say they do feel the thing in their stomach, I'm like, all right, let's give them something to help them stay with it for a minute. And they can use self-touch. That could be on the list.
Yes.
So if touching that spot in particular makes it get bigger, like the uncomfortable side might get bigger.
Yeah.
So I'll say like, maybe there's another spot that would feel pleasant.
Yes.
And tune into this feeling while you let the other thing happen. It'll just take care of itself. Right. And then what happens is they've had a little bell curve of like activation and settling.
Mm-hmm.
And the more that happens without catastrophe or without one of those interventions that cuts that process off,
Right.
of dissociation or those things, the more they're able to complete that, the more they don't have to manage it and their capacity grows.
Yes. Exactly. For me, the connection is I went to go see a therapist who was using brain spotting
Mhm.
with me because of a particular incident that was rather circumscribed, and that the same part about this feels good, and then this part down here is feeling more anxious. Brain spotting. Okay, this is my safe place, and this is the pain.
Yeah.
And that after going back and forth, I couldn't remember what I was so upset about. And what you're saying is the same thing happens here, that the bodily sensations can allow us to access that similar level of feeling, and maybe even without words.
Mhm.
Because I don't even have to know what this is. This true, Brandy? I don't even have to know what's going on in my tummy. But if I can sit with it and let it be and acknowledge it, then it might not need to keep knocking on my door. Is that
Right.
about right?
Right. Or when it knocks on your door, you just let it move through.
Yes. I'm not scared by it. I know what it is.
Right. So it's a little bit
Mm.
about acceptance, because avoiding it is what got us here in the first place. So it's like, okay, yeah, got a little stomach thing. That's not wrong,
Yes. And it's so fun as you and I get more experience in this field. I'm thinking about all these different languages, and the IFS type about managers that you spoke of earlier, and internal family systems theory says that there are ways that these different parts serve different purposes, and then if we can acknowledge them, we don't have to say they're good or bad, but just notice them and thank them for their service. It makes it much easier for things to be.
Exactly.
Yeah. Wow. One more specific question for you would be: would in any somatic therapies, not knowing any better, can I ask a question I don't know the answer to? would the clinician be the one who would put their hands on like the torso of the client and say, if I touch your kidney area, is this something that makes you feel anything? Would that happen ever, potentially?
So that is the seventh form of touch and
Oh, okay.
psychotherapy, which is psychotherapeutic body work.
Uh-huh.
And so that's something that you obviously need significant training in.
Yes.
There are a few people who are pioneers in doing that really well. Kathy Kane came from a bodywork background and later got her her PhD in psychology.
Okay.
But also taught with a therapist who specialized in attachment trauma, who is Stephen Terrell.
Okay.
And so kidney holds come from their experiences, like just being with. So if you look at the work of Bonnie Badenoch, she did a really good job at helping to combine like polyvagal theory, Alan Shore's research out of Stanford about
Yes.
the neurophysiology of attachment and that kind of thing. And also the research about the right-left brain, right? Alan Shore did that as well. But the right brain is where people think that the trauma is actually stored. And
which
so,
tends to be less verbal.
yeah. And so a lot of my efforts in the beginning are helping people to let go of some of the left brain dominance and be able to be in the right brain. We're just here right now together. And that is the state that you're born into, is you're all right brain when you're born.
No language initially. Right brain.
Mm-hmm.
Uh-huh.
And so all the communication is through touch and eye contact and
Yes.
soft sounds and things like that, right?
Yes.
Mm-hmm.
Yeah. In the analytic community, it's one thing folks will do is sit and just watch mothers and babies interact and observe what happens and what the baby does with the body and with the eyes to
Mm-hmm.
get reassurance or from the parent or explore the world. That is exactly what you are talking about.
Mm-hmm. Yep. Aileen LaPierre is another one that she does neuroaffective touch. And she actually comes from an analytic background. She was at the Young Institute for a long time.
Mm-hmm.
And so it really is about just, supporting. I am right here with you and allowing the person to experience that. And we notice, like, is that challenging? Do I dissociate when I'm in that space, or like,
Yes.
what happens for me? And a lot of times what'll happen is that their nervous system is just reading my nervous system, and they will start to downregulate.
If the clinician is in a space where they are, I'm going to say, at peace with themselves, or
regulated,
when they're able to regulate themselves and regulating in a way that's calming themselves, that by itself will help the client to mirror that.
Right. It's happening rather than a doing. That's the right left brain split. Right.
Yes.
And so whatever their experience is from a mind perspective might be completely different, because their body is like, well, I don't see any problem here, so I'm going to go ahead and accept this invitation to downregulate.
Yes.
But the person might be still trying to manage our relationship, either pleasing me or
avoiding. Exactly.
Yeah. So we kind of we can use that information.
It makes me think about young parents or parents of young children, when the caregiver, the parent, sometimes is not entirely pleased to have their physical body so needed by an infant.
Right.
And it makes me appreciate that a caregiver in that position might really benefit from the kind of work that you are talking about. And the infant's going to benefit by the parent being able to be more in touch with themselves and able to self-regulate more.
Right. And, part of, I think, is that when we have conflicting impulses, like, I want to do that because it's the right thing to hold the baby all the time, but there's a part of me that wants to say no.
Yes. And that wants space. Exactly.
Mm-hmm. Yeah. And so we look at things like the role of demand avoidance in trauma work. It's like, the need to say no and be acknowledged and respected for your no.
Yeah.
So,
my goodness. Did I interrupt you? You talked about the 7th stage about different ways of touch. And I remember you started with social all the way through to that level. Anything else you want to say?
That 7th one, the last one, was the psychotherapeutic body work. And so, those are the 2 main people, is Kathy King with Steve Terrell and Aileen LaPierre, who do that training. And it's extensive because, you want to be very knowledgeable when you do that.
And competent is the ethical term from our CAMPS ethics code. And do you want to say anything about, for anyone who's an early career clinician who wants to learn more about this kind of work? I'm grateful for the way that you've been commenting on where some of these ideas come from. Anything you'd recommend an associate or student or an intern or a early career professional might do to learn more about this type of work?
Yeah, nowadays information is so widely available. If any of the things has, drawn someone's curiosity, it's just to follow your curiosity and see where it leads, because there are, shorter workshops, there's, just YouTube videos, there's every way under the sun to get more information. But I think the most powerful thing is to have the experience.
As a client, as a patient.
Yeah. Mm-hmm.
I would wholeheartedly recommend that idea as well. If someone wanted to talk more with you, do you want to say the name of your website that someone could find you if they watch this video?
Yeah, it's brandyvanderheiden.com.
Mm-hmm. And you're here in Mountain View, California. If folks wanted to connect with you in person or to hear more. And the name again of the professional organization, the USABP.org, the Association of the
Body Psychotherapists.
Thanks so very much. And I appreciated the learning I was able to do there. You talked about PESI before, which is an online or in-person learning platform, but just to learn more. And the part that you and I would echo would be for folks in this field to spend time in the client's chair, to get to be in that position, to experience and to learn about oneself. You're talking about the way that for a somatic psychotherapist, being attuned and in touch and having worked through a lot of your stuff makes it helpful. And I would echo that with a left brain clinician as well. This idea about understanding where our hiccups and hookups, troubles come from, that's sure going to help us to figure out how to be not getting in the way of our clients.
Absolutely. Yeah.
Well, Brandy, any last words for today that you'd want to say about our talk? Anything else?
I really hope that one day in the future, like, this conversation will be utterly unnecessary because everybody will understand. And it's a lot less necessary today than it was when I started 20 years ago. So that's a victory. That
is a victory. And even the part about consent, I'm aware that has changed in our society so much in the last 20 years, the importance of that part also. But I'm really grateful on behalf of the students who watch this. They're grateful as well for you taking the time to share these thoughts and ideas. And I look forward to our continuing work together in the years ahead. So I'll say thanks so very much for being here and sharing your time. And best wishes. Thanks, Brandy.
Thank you.